Good evening, faculty members. I would like to talk on initial experience with unilateral less invasive O-arm navigated transforaminal lumbar interbody fusion or Ulio-TLIF. I would like to thank Dr. Adhikavkar sir for helping me in this study. So TLIF is widely accepted treatment modality for degenerative lumbar spine pathologies. It's starting from 1990 when Harms introduced it. Subsequently, minimally invasive was introduced in order to reduce surgical exposure and blood loss, which was introduced by Foley's in 2002. Subsequently, less invasive unilateral TLIF was introduced, which had advantages of both less exposure, less blood loss, along with that relatively less risk of adjacent segment disease, which was postulated. O-arm navigation is being used increasingly in minimally invasive surgeries in order to reduce the surgical exposure as well as increase the accuracy of the screw and cage placement. So our aim is to introduce unilateral less invasive O-arm navigated transforaminal lumbar interbody fusion technique to study operative parameters, duration of surgery, bleeding, and size of incision, functional outcome in terms of visual analog scale, and Oswestry disability index, radiological outcome in terms of fusion rates. So this is a prospectively conducted study. Duration of study was from February 21 to October 22, nearly 18 months. Sample size was 23 patients. The inclusion criteria was all the patients from both the genders aging from 16 to 80 years with having low back pain, predominantly unilateral side of radiculopathy or claudication, who are not responding for at least 6 weeks of conservative management, having multiple various types of degenerative lumbar pathologies, including PIVD, lumbar canal stenosis with facet cyst, having grade 1 instability or iatrogenic instability created during the decompression surgery. So coming to the surgical technique, so on the O-arm 2D shoots, we first confirmed the level of the pedicle, where at the index level. On the right hand side clinical picture, we can see the spinal needles inserted at the level. So 3 centimeter, nearly 3 centimeter away from the midline, we took a longitudinal incision nearly 3.5 to 4 centimeter of length. Subacute tissue dissected, fascia, muscle fascia exposed and inside with steely scissor. Intermuscular plane established between multifidus muscle medially and longissimus laterally. Once the exposure is completed, we also applied the minimally invasive reference array at 2 to 3 level higher spinous process. This is the OT setup just prior to taking 3D shoot. We have optical camera at the head end of the patient, gantry and stealth station by it. Serial dilators were inserted over the facet, which is to be taken out in order to place the self-retaining retractor at accurate position. Followed by screw insertion. On the left hand side, we see the pedicle owl, which is passing through the pedicle on the right hand side of L4 pedicle, followed by screw length projection, navigated tapping, and screw insertion. On the left hand side, we can see L4 pedicle screw and L5 pedicle screw. On downside, we have decompressed cord with the root. Over the top decompression was done as well. On the right hand side, we can see the exact placement of the cage, which is preferred on anterior 2/3 and exactly in the center, which was projected. Post-operative shoots were taken, and size of the incision was nearly 3.5 to 2 centimeters. Long screw placement was possible in anchoring to anterior cortex, and adequate convergence could be achieved because of O-arm. Post-operatively, patient was asked to walk within 12 to 24 hours. No drain was inserted as there was minimal bleeding. The result, we have 1.2 to 1 male to female ratio. Age was 55 years mean. Most commonly operated level was L4, L5, and most common indication for the surgery was unilateral lumbar canal stenosis having unilateral symptoms. Surgical time was 89 minutes. Average bleeding was 63 ml. Incision size was 3.5 to 4, and there was no complications observed during the surgery. VAS score improved significantly in leg and back. Oswestry disability index was also improved. Comparing with the other studies, the duration comparison of VAS score of leg and back was comparable, which was 2.3 and 2.2 in other studies. In our study, it was 2.5. Oswestry disability index was also comparable with others. The bleeding, intraoperative bleeding, which was observed, is also less as compared to other unilateral TLIFs, and duration of surgery was also 89.5 minutes. So, discussing the exposure, unilateral TLIF gave the advantage of intact posterior midline structures, less blood loss, less duration of surgery, and relatively early post-operative recovery. The limitation of our study was shorter duration of follow-up, small sample size, and cost of O-arm navigation. In conclusion, Ulio-TLIF is newly modified technique of conventional TLIF preferred in unilateral symptoms, giving minimal incision, low blood loss, less operative time, with anchoring screws, screws anchoring all the 3 columns with long length screws. We have few of the cases having unilateral symptoms where unilateral TLIF was done. In the revision cases also, this is a revision case where unilateral decompression was already done.